calcium is another cation I would like to talk about, and of course calcium is located in the bone, and most calcium in the bone is located as hydroxyapatite. Calcium needed for maintaining the structure of the bone and teeth. Maintain the clotting, as you know, it has significant role in clotting cascade, hormonal secretion, and cell receptor functions also will be regulated by calcium. Phosphate is another anion that's located in the bone, and calcium and phosphate go together. And most of the phosphate, approximately 85%, located in the bone. We need phosphate for high energy bonds located in creatine phosphate and ATP, and phosphate will act as well as an anion buffer. Okay. So as I said, calcium and phosphate are very tight together, and calcium and phosphate concentrations are rigidly controlled and by this equation. So calcium and phosphate concentrations multiple is a constant. If concentration of one increases, the concentration of the other decreases, and K here is a constant. Calcium and phosphate are regulated by three hormones. Parathyroid hormone, or PTH, will increase plasma calcium levels via bone reabsorption, and vitamin D, it's really a fat-soluble steroid. It's one of the fat-soluble vitamins. It will increase calcium absorption from GI intact, from food intake, and calcitonin will directly affect plasma calcium levels and will decrease it. When calcium concentration drops less than 8.5, hypocalcemia occurs, and there are several causes for that, like deficit in the calcium, or maybe related to inadequate absorption in the gut, and ionized calcium will be deposited, on the other hand, into the bone or soft tissue. You see all these calcifications in the soft tissue sometimes. Blood administration can cause it, or decrease in PTH and vitamin D. So nutritional deficiencies, if patient has inadequate consumption of calcium-containing products, it's definitely will affect the calcium levels. Blood transfusion, I mentioned, it can be a common cause of hypocalcemia, not because the blood by itself affects it by any way, but because the blood is infused or stored, I would say, in the bag in a citrate solution, and that will bind with calcium. So another cause, of course, is pancreatitis. If the lipase goes into the soft tissue space, the fatty acids can bind with calcium, and when lipase goes basically into soft tissue space, it contributes to formation of the free fatty acids that are looking to bind with something, and they will bind with calcium. And again, that will decrease the level of ionized calcium. One of the ways, by the way, to diagnose pancreatitis and see what happens, not the most direct way and not the most significant, but it will help to establish your diagnosis, the lower levels of calcium, and again, that's secondary to lipase. So vitamin D deficiency can happen. Again, ultraviolet radiation absence, how cautious are people nowadays, and also fat deficiency in the diet or malabsorption of the fat. This can be numbers of reasons to contribute to this, from the psychiatric disorders versus malabsorption secondary to absence of pancreatic enzymes. Another option for this is when a patient has destruction or removal of parathyroid gland. Parathyroid hormone deficiency can result in hypocalcemia. So there are numerous sources to cause this, and the results will be that neuromuscular excitability will increase secondary to hypocalcemia. So there are two signs, Chvostek and Trousseau sign, and rare occurrence. Again, not every patient with hypocalcemia will develop this, even with significant hypocalcemia, but you can elicit Chvostek sign by tapping on the facial nerve of this patient, and just to find where it is, just tap below the temple. The twitching, uncontrolled twitching of nose of the lip will occur, and what you do, you just irritate the facial nerve and you inducing response, nerve response. The Trousseau sign is the contraction of the hand and finger when blood flow to the extremity and to the hand, not the entire extremity, is occluded. Usually the use of blood pressure cuff is recommended to induce this. But again, these two signs are the remnants of the old school, of old traditional medicine, mostly intuitive when the lab results weren't available. Because if your patient even exhibiting those signs, your goal is to find out how much actually calcium is lacking, what's the number of calcium. So the treatment for this will be to replace the calcium in emergency situation. An emergency situation when patient presents with tetany, and tetany is like severe muscle spasm, and by muscle spasm we mean severe contractions of entire body, and most of it we're concerned about respiratory arrest and that. So at this point we can administer calcium gluconate intravenously as an emergency measure. If the calcium levels aren't that low and patient is doing well, overall the oral calcium supplements can be given. Some advocate to give oral calcium as a citrate, and there is a body of research suggesting that the citrate will be more efficient than, let's say, calcium carbonate that you can find in Tums. So decreasing phosphate intake also can be one of the ways to manage hypocalcemia long term. Hypercalcemia So everything happens the opposite way. So the blocking of the sodium into the cell increases. The neuromuscular excitability decreases. Muscle will be weak. Okay, then it's getting even worse because patients with hypercalcemia will experience bone fractures and kidney stones and constipation because of this. And again, constipation obviously is a result of hypercalcemia and the result of decreased muscle tone in the gut. So how to treat? First of all, you need to evaluate before treating, and you won't be able to elicit any of the signs like Phosphate and Trousseau sign, but at the same time, you can truly diagnose this based on your lab results. And again, depending on severity, you may proceed with oral phosphate administration. Remember, the phosphate components are only indicated when renal function is normal, and if you read the solid deodorant packaging, it's a consult with physician if you have renal disease. That's what, because the deodorant may contain phosphate, and that's what can affect the patient or whoever, the consumer. But treatment options will include normal saline administration, IV, and basically to dilute, and also another way to deal with it to administer calcitonin to regulate it. But to treat this and to understand this, hypercalcemia doesn't occur by itself. It occurs secondary to some cause, and one of the causes also can be the parathyroid will be overly active or have tumor and have parathyroid hormone excess. I remember a clinical case from last year. We had a patient with history of parathyroid tumor, which resulted in complete thyroid removal for this lady, and of course parathyroid too. And she was receiving the parathyroid supplements. When she was receiving parathyroid supplements, it resulted in a crisis with the increased calcium in the plasma, with all the consequences, which was corrected with calcitonin. We met her on her next admission, and we faced the opposite problem, and she had multiple other disorders like multifactorial, but at this time her calcium levels were very low, and this is the first time I seen the actual Phosphate and Trousseau sign induced. So at this time, patient became progressively worse and start having slurring of the speech and start exhibiting tetany, and the solution was to the condition to administer to administer intravenous calcium gluconate to deal with this condition. Again, this case is fairly clear-cut. It's absence of parathyroid, and the regulation of it was done by artificial means. By regulation of parathyroid hormone was done by artificial means, and hopefully eventually she will be in the normal range and the consequences won't happen. But until then, she had these 2 crisis situations on 2 different admissions, which were promptly taken care of. But it was especially the one we witnessed with tetany and slurring of the speech, and both signs positive. It was quite traumatic and quite significant for the patient herself. But as far as I know, she did well, and she was discharged and never came back to the hospital. When we're talking about hyperphosphatemia and hyperphosphatemia, we will see in hypophosphatemia case that patient may have osteomalacia, muscle weakness, bleeding disorders secondary to platelet impairment, anemia, and leukocyte alterations. And one of the most common causes to cause this, it's antacid abuse. So we all love TV commercials and, advertising all over the counter and prescription drugs to consumer. However, if patient has untreated gastroesophageal reflux, and TUMS becomes the answer, so at that time, antacid will bind significant amount of phosphate and result in hypophosphatemia. So patient may present with muscle weakness, and something so innocent as antacids may result in complete energy metabolism dysfunction. It may result in muscle weakness of respiratory muscles, respiratory failure, and cardiac arrhythmias and death. So osteomalacia again may occur as a response to low phosphate level, and again low phosphate level can result from antacid abuse, one of the common things. And hyperphosphatemia is elevated level of phosphate, and at this time what can happen, phosphate goes with the calcium, and when phosphate goes with the calcium, so hyperphosphatemia can be related to hypocalcemia. So basically, this may include, to fix this may include the treatment of hypocalcemia. So remember that the equations we mentioned before, but again, high phosphate levels are related to low calcium levels. To make long story short, the symptoms will be the same as symptoms of hypocalcemia because it always correlates together. But one of the things I want to mention, it's if hyperphosphatemia continues, or it's possible that calcification in places that we don't need may occur. And by places we don't need, we mean lungs, kidneys, kidney stones, and even joints. How to treat this and what to do in this situation and hyperphosphatemia. Of course, again, you'll never go wrong by saying that let's treat the underlying condition, let's treat the source, but at the same time, aluminum hydroxide may be administered, and aluminum hydroxide is one of the antacids you can buy. So you treat it to reduce the phosphate, and you're doing it in GI tract. Okay. Aluminum is a good drug in this aluminum hydroxide, but it can be still resulting in deposits in central nervous system. So the science keeps developing, and there are other binding agents again, but aluminum is still possible to use. But again, to finish this topic of hypophosphatemia and hyperphosphatemia, please remember that the main thing here, main objective here in treatment, to treat the underlying source, because these disorders are usually consequence of something else that resulted in alterations of phosphate level.